Okay, so we are to part 3, last part. We're going to talk now about chronic obstructive pulmonary disease, COPD. So let's get to it. So again, bring you back to the decision tree for COPD. Again, physical activity history is the first thing we need to find out. 30 minutes, 3 times a week for 3 months, moderate exercise intensity. In this case for COPD, let's say they answer whether they answer yes or no. They have no CMR, so they're going to go through the no CMR side. We're still trying to find out if they have, as they might have others, already have also cardiovascular disease, then that would be a different decision. But if they have none, if they have no signs and symptoms, then and if they're not active, then you start light to moderate exercise. And if they are active, which maybe some could be slightly active, no CMR, no signs, they can continue moderate to vigorous physical activity. So make sure you remember how to work with the decision tree. So let's talk about COPD. Move myself here. Where? Here. Okay. So COPD can be characterized by either chronic bronchitis or emphysema. And we'll talk about those two the distinctions. It is permanent lung disease. Remember when we talked about asthma, it's reversible. Asthma, can go back to not having a problem, so it just depends on the environmental conditions or the triggers or disease if they're ill. This is not the case here. This is permanent lung disease, and it's going to get progressively worse with time, so it's not going to resolve itself. Lung disease that becomes progressively worse, and it's completely it's not going to be completely reversible. So this is, I need to fix that. I noticed that picture is blocking part of my words. It is not, it should be not completely reversible. So also known as chronic airflow limitation. Two main forms of COPD, emphysema, which is damage to the lungs over time, and then chronic bronchitis, which is long-term cough with mucus. I did put these two links here from Khan Academy, which you also have in your module, so make sure you review them. Those do a really good job of explaining the differences for emphysema and COPD. It is something that I do want you to understand for our next exam, so spend some time watching those two videos so you can see the difference. But simply put, chronic bronchitis leads to more inflammation. Looks here, if you remember what I showed you with asthma, looks a lot like what asthma looks like, except in the case of asthma, it resolves itself. In this case, it doesn't, and it interferes with inhalation and exhalation, with ventilation. And in the emphysema case, the air sacs, the alveoli, actually, you're gonna have some physiological dead space. So space in the lungs that cannot be utilized for breathing. So that's gonna be a problem for them. Most people that have COPD will have a combination of the two, with some being more of a problem at times than others. But if they have an infection, for example, the chronic bronchitis is gonna be worse, and so they could more than likely have both. And you can also have someone that has not only COPD, but also asthma, and also maybe something like cardiovascular disease. It is the third leading cause of death. If you, again, that's an active link, so if you click on that, it'll give you some current statistics. It goes, depending on where you look, it could be third or fourth leading cause death, depending on what year it was taken. But it is a significant problem for Americans, 15 to 30 million people. So depending on what you look at, anywhere from 15 to 30 million people. Why the differences? Well, 15 maybe people that have been diagnosed, but with the projections, there's a lot of people that never get diagnosed just because they don't go and seek medical care or medical treatment. And so the estimates are that from about 30 million people in the United States may be suffering from COPD. And certainly a major cause of healthcare costs and morbidity and disability in America. There's an infographic that highlights the information. By the way, if you use infographics like this that are not yours, you didn't create them, or any other charts or graph or figures, you can cite it in a long version like this, like I did, or you can just put a short citation, like the last name of the authors with the year, and make sure you cite it on the end. But here in this one, you see 15 million people, more than 150,000 deaths. Is more likely to occur in rural areas. Things to do to avoid it: not smoke, make sure you get the flu and vaccines, just because any infection with someone with COPD could end up being a very life-threatening condition. So stay active, and then more than likely for COPD will be part of rehab. So risk for COPD. Let me put myself up in this corner. Maybe this corner will work. We'll try that. So risk for COPD. We'll talk about that study in a little bit. Smoking is the main cause, like it is for so many other things. So stop smoking. But it could also be due to work hazards, exposure to certain gases or fumes in the workplace. Secondhand smoke. And that could also be workplace, if you work in a place where a bar, for example. And then cooking fire without proper ventilation, but really smoking is the number one. Hallmark for COPD that we're going to notice is that because you're not doing what the respiratory system is supposed to do, deliver enough oxygen to the working muscles and remove carbon dioxide, those tissues are not going to be getting enough oxygen, and so there's loss and atrophy of skeletal muscle, which leads to dysfunction. Primarily, if you think about what muscle fibers utilize oxygen, primarily that would be type 1. So type 1 losses is what may happen. And so when you couple that with the fact that many people with COPD will be older adults, and older adults also lose type 2 muscles fibers, so then you have an increased risk for a higher degree of sarcopenia happening in folks with COPD. So serious concern. As a result of that, they're going to lose strength and muscle girth. So circumference of the muscle, cross-sectional area of the muscle being smaller, which, if you remember your strength, how to gain strength, that's one of the ways that we gain strength. So this study by Kinley and Wong compared leg strength of folks with COPD versus those that are normal, and you can see this how much more we look at leg strength, right? Significantly lower, and although they're all lower, but you can see that the leg strength significantly lower, and that's leg strength is necessary for getting around your day, walking, and so as that couple that with being older, that really decreases the longevity. So, and there's some other markers that if you're not able to walk for the 6-minute test, for example, if you're not able to walk a certain distance, you can predict someone's ability to, how many more years they're going to live. So that's a serious concern. So hopefully when you look at this, you think, oh, I'm looking at strength training, then I know I need to focus on increasing skeletal muscle strength. Treatment. So definitely, if they're smoking, they need to quit. Sometimes we may use oxygen therapy. And oxygen therapy now is a lot easier, so it's portable. They can take it with them wherever they go. And you definitely should not be smoking if you're on oxygen therapy. I know people do, but that's not, no, it's not supposed to be doing that. And other pharmacological therapy that induce bronchodilation, decrease inflammation, and prevent respiratory infections. So they could be in a whole slew of different medications. They should go through pulmonary rehabilitation, and many times people with COPD, if they have the insurance, they will remain in a pulmonary rehabilitation place or a rehabilitation clinic uh, for their exercise, where they're monitored. In more extreme cases, they may need a lung transplant, or they may have to get rid of certain parts of the lungs to ease their difficulties. And so our focus in training or in exercise is to lessen or delay disability. So keep them independent, keep them walking, and if they're losing leg strength, they may become more disabled. And like I like to say, think about if they're not using this, not using the cane, to postpone that as long as we can. Once they start using the cane, then even less leg strength is required to walk. And so as less leg strength is required, then they can then rely on a walker. And then after the walker, then comes the wheelchair. After the wheelchair, they're bedridden. And after they're bedridden, you can start a time clock. Life is not going to last much longer, so especially older adults. So that's our goal in exercise, is to, if they're on the cane, get them off the cane. If they're on the walker, get them off the walker and back on independence as much as we can. So exercise tests that are important and relevant here. So we're going to do a prediction of for exercise intensity. You cannot use the heart rate formulas. They would not be meaningful for them because they have limitations, and it's not so much cardiovascular, at least not initially, but it's respiratory. So they are not getting enough oxygen to the working muscles, right? So those are not going to be appropriate. So using any of the heart rate formulas will not work for intensity. So we'll talk about what may work. If you click on the American Thoracic Society 6-minute walk test, this is the actual handout. They explain how to properly do the 6-minute walk test. And if you look at this, it's a video that we also seen in the assessment part. You can take a look at that. Let me move myself over here. Okay. You can take a look at that, and it shows you how to do the 6-minute tests. And so that's an appropriate test for COPD, and you'll see that that test is used to predict longevity, how many more years they're going to live based on how well they do on that test. And tying it back to leg strength, so the more leg strength you have, we'll take a look at that later when we look at older adults. The more leg strength you have, the faster you walk. So it's all tied in together. You cannot use treadmills because the treadmills actually help you out, so you want to use the hallways or wall to wall, whatever distance you have in your location. Other tests that you're going to perform, certainly the spirometer test, that would be one that you would have to do to determine, and maybe that day, and again that day before exercise, but just to see where they're at, to establish a baseline. The saturation, this is what I was talking about earlier. With asthma folks, you also use this. In this case, it looks like it's at 98 maybe, or is it 86? 86. So not so great. In the 80s is not so great. You want it in the 90s. 100% saturation would be fabulous, but in biology, it's very rare to get anything like that. So in the 90s would be good, especially with someone with COPD. Because if it's less than 80%, then that's determination criteria for the activity. So some assessments you would have for the graded exercise test, it would be a modified test. The boost protocol, starting at 10%, would be undoable for most people with COPD. So you would have to modify that, like we talked about in the assessment section. Extended stages, smaller increments, slower progressions, and only increased speed only, and not the incline. Okay. Move myself over just a teeny bit. Okay. So you can see this gentleman here. He's exercising with his oxygen tank. So folks with COPD, that's what you will see. And he has a whole oxygen tank, but they do come in a lot more easier to carry, a more fashionable types. Yeah, they would be exercising with their oxygen. And as far as COPD, they do need a complete health screening for coexisting factors. So we're looking for any signs and symptoms of cardiovascular disease if they're not being diagnosed, diabetes, and it's not out of the question to consider a medical evaluation if they haven't had one in the last year. So that would be a good thing. And if possible, pulmonary rehab would be the best location for folks with COPD, but sometimes because of cost, that's not an option, but that would be the ideal environment for them. And exercise is not going to cure COPD, as we talked initially in the semester. Exercise doesn't cure most of the conditions we're going to talk about, but it does serve as relieving some of the symptoms and improving the quality of life and activities of daily living. And so if they were not previously active and sedentary, it would be prudent to have them get a medical evaluation if they haven't done it in a while. So exercise benefits for COPD, I don't know why those didn't come up, but so you can see all these folks here in this picture. Yes, usually going to be older adults. The lady in the bike exercising with her oxygen. You can see the exercise physiologist in the black jacket monitoring the older man in his red sweater. So that's what you might find in pulmonary rehab location, really cardiac rehab, any one of those rehabilitation centers. And sometimes it's combined with physical therapy as well. So exercise capacity will increase and the quality of life improves. And this is true for all of us, right? Both socially and during the activities of daily living. And endurance training has been found to decrease that systemic inflammation. Remember, for bronchitis, the inflammation is the biggest concern. The observed decreased shortness of breath. Dyspnea relates to shortness of breath from exercise. In this population, it's not the result of improvement in lung function, but from peripheral changes in skeletal muscle. So that's a good thing. And so there is no consensus on the optimal protocol for an exercise program because there is so many individual differences in how much exercise they're able to do. So a proper assessment initially and screening before exercise is essential. And as far as resistance training, know that it improves strength and mass, but it has no measurable effect on exercise capacity, so it's not going to do that. On shortness of breath or quality of life, but it is still recommended, and it does tend to improve their perception of how they can get along through their day, and activities of daily living. So that's a good thing. And then this is another Klein handout created by ACSM to give about exercise. It's kind of nice about exercise and COPD and the benefits of it. So I put that in there for you. So this is, where can I put myself? Let's try down here. Okay. So this is a staging, or it's done by it's known as a global initiative for chronic obstructive lung disease and for COPD staging. And as you see here, it is about forced expiratory ventilation. And so you see the more severe is directly related to forced expired ventilation. So less than 30, you don't want to be there. That's respiratory failure. So you can see how it progresses. The goal is to keep folks over 80. So over 80 or above is what we want to do. This is they also recommend the load index for 4 factors that will predict the risk of death in 4 years in folks with COPD. So let's take a look at that. And so here is the BOD index. If you click on the points, on the BOD index here, if you click on this, oops, I went too far. Okay, so if you click on the points of the BOD index here, it will actually let you test it out, shows you how to do it. So the forced expired FEV percentage predicted, that's important. How far they walked, and shortness of breath, and body mass index. So what you may note here is that the greater the forced expiratory rate. The FEBS, the better. The greater the distance, the better. And the lesser the shortness of breath, the better. And you can also detect here that maybe this is surprising, that actually having a higher body mass index is going to be a better score. Why? Well, realize that for those that have had COPD for a while, they're going to have muscle wasting, severe muscle wasting. So their BMI, they tend to be very thin, skinny. If they were previous smokers in particular, that would also be the case. So being small and low BMI is actually a worst case scenario. So for someone that gets the higher the score, the worse off you are. So if you have let's say 7, a high score like that, you could say that it would predict that your chances of living 4 years, maybe 18%. So you have an 18% chance of still being around 4 years from now. So that is quite scary, but it helps to predict where they are now, and then so we can, from the training world, we can look at these factors and see how we can improve upon definitely the leg strength to improve the walking distance, and then the forced expiratory ventilation, FEB. So here that brings us to special considerations for exercise. I don't think I can put myself there. I don't know where to put myself really. We'll try there for now. Okay, and I'll promise to talk about the study in a minute. So as far as exercise, cardiovascular exercise, they do have a reduced exercise capacity. So trying shorter intermittent sessions may be the first way to go. So maybe only a few minutes, where you say do a lot of minutes of exercise and rest. You cannot use heart rate. You have to use rate of perceived exertion, but really shortness of breath indicators are more traditionally used. Myself here for now that you saw that it's about exercise, and then strength criteria. Well, our focus may be in strength. Work on the breathing muscles, like we talked about with asthma, but maybe the strength of the breathing muscle, the scalenes, the sternocleidomastoid muscle, the serratus anterior. Upper extremity resistant training is fine to reduce shortness of breath, but cardiovascular resistance training may not be the best. So arm ergometers, for example, will not be a good thing because it raises the oxygen demand too fast. So whole body resistance training is good as well. So in this study by O'Donnell, I actually put this in your reading list, compared the shortness of breath and between someone with COPD and normal. You can see the big distinctions. Tidal volume, you can see that, how many breaths per minute as the intensity increases, you can see that, right? Sharp, where they have to stop exercise here. And so you can see significant differences in lung volume, right? So all of that shows, and they end up with hyperventilation, where they're inflating the chest cavity as exercise continues on. So here's a fit for COPD. Frequency at least 3 days a week, 2 to 5 days a week. And again, going with not the heart rate formulas, none of those will work, but preferred is the shortness of breath. And so I start with 3. So the goal is to not get the onset of shortness of breath, to delay the onset of shortness of breath. So here's the modified Disney scale. So we want to stick here and really go below the severe, because once they start to have shortness of breath, they become fearful, and that's one of the things we don't want. We want to avoid. So we can maybe be conservative. Try a couple of minutes and see how they deal with that. So intermittent exercise, and then work up to more sustained activity. Mode, large muscle groups. Walking is great. Stationary cycling requires muscle strength to overcome the resistance, so that may be something to consider, because they do have lower leg strength, so that's something you can work with. Be careful with the arm ergometers. It actually is going to increase shortness of breath unnecessarily. resistance training and flexibility exercise. Those are all good. So this is from your chapter 5, a summary of everything I just said. So look at the intensity, starting as low as 30 of peak work rate. So this is based on the test. So if you did a modified ramp test on the treadmill, you're going to use that percentage of what they did, the max they did there. And so that's what that relates to. So you would do, again, based on your modified assessment. So you would do that. And then intensity for resistance training, what does that mean? 40 to 80. So if you would predict that they could do 50 pounds, you could do, let's say 100 because it's easy. Let's suppose they could do 100 pounds on something on a leg press. They could do 100 pounds, then you can start with 40 pounds to work with. So, and be conservative. Always go with the lightest. See what does that do to shortness of breath. So you're monitoring the shortness of breath. Avoid overexertion or doing too much, too soon, too fast. This is true for everyone, but certainly for those with COPD. Look for lightheadedness, confusion, nausea, and dizziness. And these are always things we're looking for, not just for COPD, but certainly we look at that for diabetes, and next week when we look at cardiovascular disease, that's always going to be a thing. Or maybe I say female because that might be my experience, that client that shows up at 5:30 and tells you that she hasn't eaten anything all day, and you were just having a high intensity workout. So it could be that person too. Chest discomfort. They may report it as just nausea or just pressure. They have unusual shortness of breath. So not at times when you're supposed to get it. So maybe they just bent over to do something and they got it. Times or heaviness in the chest, heart palpitations. So some of these may be signs and symptoms of a heart attack. So, all right. So here we are. That brings us to our post-test. I know it's been at the beginning, but how did you do in these questions? So let's go through them. So doctors, true or false, doctors can diagnose COPD with a simple breathing test. Is that true or false? It's true. They can use spirometers and they can tie it to their computers and get a complete readout. And they don't have to say you need an MRI, you don't need blood tests. They can diagnose it with a simple breathing test. So true. Number 2, there are 2 main diseases that cause COPD. True. But what are they? What are they? If you said emphysema and chronic bronchitis, right. Smoking is the number 1 cause for COPD. You should just be shaking your head. Yes, 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 yes. True, it is. Stop smoking. It's not. It's so bad. It's not just about heart disease and strokes and COPD, but also cancer. Lung cancer is number 1 of all the lung cancers, of all the cancers. So quit smoking, and tell people around you to also quit. Cigarettes. You can have both COPD and asthma. Yes, of course. You can have COPD and asthma and diabetes and cardiovascular disease and osteoporosis and all sorts of stuff. So yes, that is true. If a child has asthma, he should not play school sports. This is probably part of your question for your discussion. Of course he can. Okay, so this is maybe an old school thing that doctors used to tell parents that had children with asthma. Of course they can. You just have to take proper precautions and prevent triggers. So, many people with asthma also have allergies. True. Yeah, so and controlling the allergies is part of the precautions that need to be taken. Baseball is less likely to trigger exercise-induced bronchoconstriction, EIB, than soccer. Yes, it is. And I'm hoping in your discussion this week that you'll research why that may be. I think I told you a little bit about it, but tell me more about it. And then what other sports that are more like baseball and other sports that are more like soccer may not be the best. Although, again, you can't tell me whether or not there's class athletes in all of the sports. And number 8, cold and dry air is best for preventing EIB in people with asthma. No, false. Right? Actually, what kind of air is best? Warm, humid air is best. Your nose filters the air in just like your AC, so it's just the right 98.6 temperature at just the right humidity that your body needs for better utilization of it. So, and then not to set off any irritations, especially with those people with breathing difficulties. So, actually, so 8 would be false. Okay, that's all I have. See you guys on the next one. I think I'm going to try using this app. Alright, see you in class.